Hello, everyone, and welcome to our second Pulse Check series webinar. My name is Rashid from StudyTeam, and I will be your host for today's session. So over the past few years, we have seen StudyTeam being actively used and adopted by sites across the globe as part of their day-to-day workflows. But beyond workflow management, there are equally critical challenges that sites faces, particularly when it comes to engaging with their communities. And that's exactly what we will be focusing on today. How to drive real impact in community engagement, bringing together practical experiences, tools, and insights from experts working closely with communities on the ground. And we are really excited today to be joined by our experts from the South African Medical Research Council, who will share their perspective on how community engagement plays a critical role in clinical research success. Here's a quick look on what we'll be covering today. We will begin with the speaker introductions. Then we will explore what meaningful community engagement really looks like, from identifying key stakeholders to actively listening to communities. We will discuss why community engagement is an ongoing ethical responsibility rather than a one-time effort. And finally, we will touch on language, cultural sensitivity, and how to navigate real-world challenges before closing with a live Q&A session. Meanwhile, feel free, everyone, to share your questions throughout the webinar on the Q&A box located at the bottom of your screen down there. And we will address as many as possible at the end. Before we dive into the discussion, I would love to briefly introduce StudyTeam for those who may be less familiar with it. StudyTeam is a cloud-based patient management solution designed to help study coordinators streamline recruitment and patient tracking workflow. It reduces manual admin work, centralizes recruitment activities, and it is provided free of charge for sites. As part of our continued collaboration with sites globally, we are also working on introducing improvements designed to better support real-world site workflows. Some upcoming improvements include a redesigned task list to help sites prioritize recruitment activities more efficiently. And we are also introducing a more intuitive workflows aligned with the actual patient journey, along with a simplified referral management experience to reduce admin burden for the site teams. Building on that, StudyTeam is really designed to create value for sites. It reduces the need for duplicate data entry and manual sponsor updates, saving that way significant staff time. Sites can onboard unlimited users across departments, making collaboration much easier, and everything is centralized from patient referral to scheduling and recruitment tracking, giving sites a clear real-time view of their progress. I am now very pleased to introduce our speakers from the South African Medical Research Council, Professor Catherine Aurel, Unit Director of HIV and Infectious Disease Research, Ms. Nengi Mtetwa, Project Manager, and Dr. Elizabeth Spooner, Specialist Research Clinician. The SMRC team brings an extensive experience in community engagement, particularly in the context of HIV and infectious disease research. They will be sharing practical insights, challenges, and lessons learned from working directly with communities. Hello, everyone. Welcome. And at this point, I would like to hand the discussion over to our speakers from the South African Medical Research Council. Thank you again for joining us today. And over to you, Dr. Spooner.
Thanks, Rashid, and hello, everyone. I'm going to be talking about research stakeholders and our communities. Next slide, please. Okay. So just from the MRC, our statement that we recognize the catastrophic and persisting consequences of colonialism and apartheid, and we acknowledge our historical role in silence during that period, and we commit our capacities to the promotion of justice and dignity in health research in South Africa. Thanks. Next one. So this is just where we are. We are in Durban, which is a city on the east coast of South Africa, and we have got 6 clinical research sites in our municipality. As you can see, 3 in the north, 2 in the south, and I'm the PI at Bothas Hill, which is that western site there. Next slide. And I'm just skimming through the leadership of our unit, and specifically because I've noticed with our communities that the leaders of our unit are very important to them. And I might have been in the unit for 10 years, but they remember back the 30 years that 20 plus years that our unit has been in existence. So just that leaders are very important. So we were started by Prof. Geeta Ramji, and she handed over in 2019 and moved to another Aurum, which is another research institute. And then she was one of our first deaths from COVID in South Africa. So she's remembered as well for that. And she set us up with NIH funding through the DAIDS networks. Next slide. And then we had Amina Goga, who led us through COVID, and she's now at the WHO. And then we had Charles Shewasonge, who also has gone to the WHO. We have lots of exports, and he led 2 units in the MRC simultaneously. Next slide. And then we had our Deputy Director, Tarusha Chetty, leading us in 2024. And then from 2025, Prof. Oral took over, and she's also a professor at the University of Cape Town and leads our unit here in Durban. Next slide. And so just to speak about all the important stakeholders and partners that we have in research and how important it is to interact with them. So these are the remote kind of partners, and we have SAPRA, who is our national regulator that we obviously have to get permission for to do our clinical trials, but we also choose to actively engage with them, and they have stakeholder engagements, and we always attend and make ourselves known so that when we send a submission in, they know the MRC, they know we've been doing clinical trials for a long time, and so we interact as much as possible with them. We also have our National Department of Health, and specifically our Provincial Department of Health, because that's who we get our approvals from for our studies. But again, it's not just that we send things to them and get letters back approving, that we also engage with them, and they have stakeholder meetings, and we invite them to our research days. We go to their research days. So we know them and they know us. They even come and have done site visits to our sites. So it's always good to actively engage. We have our MRC Ethics Committee, who also have visited our sites, and we engage with them as much as possible, as well as just needing approvals. And then we have broader stakeholders like through our networks or sponsors. Hank there is the HIV/AIDS network coordination that we are involved in and have members of our units represented there. And then there are also global cabs. Some of the sponsors have global cabs. A lot of the networks have global cabs. And so our cab members are represented there. And then there are also SACRAs, the South African Clinical Research Association, that we are involved with. And SATAC is another an advocacy strengthening Africa's health technologies that we also have members that are part of that. Next slide. And then at a more, still external to our organization, but at a more local level, we obviously have that provincial health department that I spoke about, but we also have our local health facilities, the clinics, that's St. Mary's Hospital, which is the hospital that's closest to my clinic. So if participants get referred, they might go there, and we get to know the doctors there. And then we also have local research organizations, CAPRISA, BITS, MRU, both are in our city doing clinical trials similar to us, so we interact with them and again, go to their meetings, they come to ours, we borrow test kits if ours run out, we have a close relationship. Health Systems Trust, another research organization, and they do health system strengthening research, but we bump into them at the clinics and we have good relations with them. And then local NGOs, there are many of them. I just put the Valley Trust there because that's the NGO where my clinic is. We rent space from them, and there's also a public health clinic on the property, but NGOs come in all shapes and forms, and we always interact well with them. And then we also have the university partners as we're doing academic research. And there's University of KwaZulu-Natal and then UCT where Catherine is based. And we also interact with other CABs in our area, and we have had joint CABs for some studies across different sites. Next slide. And then this is now into our research sites. Each of our sites has a community working group. So this you'd probably know as a CAB. But our CABs chose to be called community working groups because they didn't want to be advisory boards. They wanted to be more hands-on and representative. And so we have meetings regularly, and we've just put out some guidelines to encourage rotation because some of them have been with us for a long time. And we always want members to be active and to give other members of the community opportunities to be on our community working group. So we just choose people from the community who are willing and who represent all facets of our community. So they might be nurses, community health workers, the House of Traditional Leaders. We have quite traditional communities, especially out in our rural areas. So we need to be represented there, and they have war room meetings, and our CLOs go there, our community liaison officers. They might be pastors, members of key populations, NGOs, who come to our meetings, which are quarterly, and then we also have an annual general meeting. Next slide. So that's a picture of our AGM with all the sites CABs coming together. It's always a fun meeting and nice for everybody to interact. And we do reimburse our CWG members for their time and their transport, but they do give up their time freely. It's not, we certainly don't compensate what they would be getting. But we do give them opportunities to travel to investigator meetings, some of them overseas, if they require community representation. And we always present our upcoming studies that we have designed or that come to us and have very active input. And they really are experienced, and they sometimes go ahead of us because they were asking for TB research long before we started TB research, and they were asking for adolescents in research long before we managed to start enrolling adolescents. So they really have led the way in some areas. Next slide. And this is now the team that works at our site. We have a community manager, that's Lengi, who's going to speak next. And then we have our CLOs, one per site. We have community recruiters that also can work in the clinic. We have field workers that are based out in the field and drivers that help to get us around. Next slide. And just about our community site team, just some things that we've learned is it really is beneficial to have staff that have lived in this local community. And so quite a few of our staff have, grown up in the area and so respected. And I'm often aware when I go to a meeting that the reason the doors are open is because Clifford has, grown up in this community and they know him. And he just paves the way for that. So reputation and history are really invaluable, and they have their ear to the ground, and they can, pick up what's going on and who needs to be spoken to. And their ongoing presence really builds confidence. And just that we must always be transparent about our challenges. If we're having funding challenges, we had some retrenchments, we let everybody know, what's happening, and they really appreciate the transparency. And then also to continually address misperceptions and myths. One of the ongoing myths that we're always addressing in our communities is they call us the clinic that buys your blood. And we always have to say we are, we don't buy your blood. We do give reimbursement, but you're part of a clinical trial. We do take blood samples, but it's because, you've chosen to give consent. So, so that's my presentation. So I'm going to hand over to Nangi now. Thanks.
Hello, everyone. Today I'll be talking about community engagement as both an ethical foundation and a continuous process. And I will also be sharing practical tips and lessons on how we have been able to navigate our relationships, build and maintain trust, especially with our stakeholders like committee advisory board members and the general stakeholders. Next slide, please. Community engagement is grounded in GPP, which means that our research must be relevant, it must be equitable, and it must be respectful to the communities, participants, and other general stakeholders that we work with. It plays a critical role in preventing exploitation and promoting justice and mutual benefit between researchers, participants, and the communities. For the South African Medical Research Council, our research is always guided by the Research Ethics Committee, which ensures that a community's interests are always protected. Next slide. It is therefore very important to understand that community engagement is not just a once-off thing, but it must be something which is continuous that runs throughout the entire research life cycle. If it starts from planning to implementation to dis dissemination and even post-trial accesses where we engage communities and stakeholders, as well as giving back to the communities to plan for the future planning of new projects. So this process always help the unit to build a research literacy, improve trial design, feasibility, as well as enhancing the uptake of our clinical trials by the study participants. We also ensure that we conduct a research which will be able to translate research into policy and practice, which are important processes when you conduct clinical trials with humans. Next slide. This slide is talking about working with the communities to build different relationships, which is effective to sustain our clinical trial. We always start by mapping our stakeholders, including the community leaders, participants, some members of the civil society, as well as other research organizations. We always ensure that our communication is user-friendly and we use the language which will be easy to be understood by the communities, and it must be culturally appropriate. It is therefore important to recognize that groups are different. Therefore, we always ensure that we segment our audiences according to the information that we intend sharing with the stakeholders. Next slide. Committee Advisory Board and committee liaison officers are indispensable partners in our clinical work. We cannot do without them because the Committee Advisory Board members act as watchdogs for the research that we do, and they ensure that we conduct research that is ethical and ensures that we remain conducting research which is beneficial to the communities. On another hand, the committee liaison officers act as a bridge builders. They always connect researchers to the communities, stakeholders, and our study participants. Next slide. This slide is talking about trust. Building trust requires early involvement, transparent of the community stakeholders, even before the formative phase of the clinical trial. We always respect the mutual benefit, especially in contexts where there may be historical mistrust. In our work, we have seen that the value of co-creating solutions with the committee advisory board and the stakeholders across different projects, namely HIV prevention studies, TB, and BioVac vaccines, is always crucial to ensure that trust is built by working on the real life life problems of their communities. And when we engage the communities, we always apply the three P's framework, which talks to empowerment, partnership, and protection of the research that we do. Can we move to the next slide? So this slide is talking about trust, that it is always important to ensure that a trust must be consistent and meaningful during our consultation. In practice, we always aim for the quarterly meetings whereby we engage the community advisory board members about the new studies, the current studies, as well as results dissemination. We always continue with the community mapping even when the study has been initiated, and we use different strategies like doing outreach programs. So we attend community meetings, we engage with a radio to share our studies, or maybe if we aim to spread the word about our work that we are doing. The community team will always do door to door to show that they are with the communities, as well as conducting community dialogues in the communities. What is important is that every work that we do is documented in order to ensure that we are able to go back to the communities and give back about what we found. Yes, so we can move to the next slide. When we engage stakeholders, we always strive to see that we engage them fully so that we don't have challenges where our engagement is weak, leading to negative impacts. These could include the lack of understanding about our work, poor definition of their roles, as well as the value of engagement and perceptions about our work. So these negative impacts could be caused by competing priorities, limited resources, as well as lack of trust. And there are, at times, you find that there are barriers, such as platforms where we can engage the communities. At times, the times are limiting when the community participants are at work, when we are out in the communities, or maybe the location that has been selected is not well effective to be able to allow us to engage the communities. Let's move to slide 9. Moving on to this slide. Sorry. Moving on to this slide, our priority is to ensure that our research is community informed. We don't just conduct a research which is not relevant to the communities. We always ensure that our clinical trials that we do will be able to address the diseases that affect the communities, and it must always promote equity as well as translate into research and practice. So today, the key takeaway is that community engagement is both an ethical, continuous process. It is not just a once-off, as well as to add that stakeholders like CAP members are not optional, but they are essential partners. Trust is always built by being transparent, consultation, and ensuring that we engage our stakeholders throughout. Next slide. To conclude, I would like to share with you that community engagement is very critical, because it ensures that our research that we do is going to be beneficial to the communities. And it also aligns with the GPP principles, which we always work along as the South African Medical Research Council. Thank you. I'll hand over to Prof. Catherine. Thanks.
Thanks, Klingi and Beth. I think we're keeping to time very nicely, so we should have great time for question and answers. I'm going to speak to community partnership, looking at language and cultural sensitivity and resolving challenges. And I'll use 3 examples that we have come across in running our research studies in the last couple of years, both in KZN and in the Western Cape, because I work across both camps. Next slide, please. As both Beth and Thangi have said, our community should be at the heart of all our research. Our trials need to answer critical questions that are relevant to the community involved, and research should be conducted with the community moving together with us rather than on people in the community. There's many older criticisms that sort of pharma companies come in, do the research, and then disappear without the product being available to the communities where the research was conducted. And so part of our ethical process is to be sure that we move with the community, we answer questions that are relevant, and we also, as researchers, have a responsibility to make sure those products are available to the community after the research has been complete. We also try to begin our engagement with the community before we have a research study in place. So where we have the opportunity to write a grant, we make sure that we have involved the community, heard the community's voice before we actually submit the grant, and that is makes our work a lot stronger. So we use community working groups or advisory boards to encourage trust, respect, and transparency between researchers and community. And an informed and empowered community support ethical, participant-centered research. The connections that Beth and Thangi have spoken about encourage bidirectional learning. And quite a lot of the time we learn from our communities, and it also enables us to have a connection so that when new things come up, COVID vaccines and things, we can actually pass information out into the communities that is correct and empowering for them as well. So it's really important that these, and I think we've all mentioned this, that their people give us their time, and we have to, we give our time back, and we treat each other with a great deal of respect because we really value these relationships enormously. Next slide, please. So the impact of our community relationships means we can improve our study enrollments, we can improve our retention and adherence outcomes, we strengthen public trust in science and the health system. And when that goes wrong, we end up with things like vaccine hesitancy, which we saw in COVID when science moved too fast, didn't bring the communities along with us, and we ended up with problems that is going to take years to undo through a process of re-education. We also build the community capacity to engage in future research and advocacy, and we ensure that health research benefits are shared and aligned with community priorities. I always think of the early prevention studies, we have very successful prevention options, but implementation and rollout of those options has been very, very slow. And you kind of wonder if earlier and bigger community involvement would have actually assisted in the rollout of these products after research was complete. Next slide, please. So the three current topics, language and current cultural topics that have come up and have filtered up so that I've been asked these questions is the concept of chest feeding versus breastfeeding, inclusion of pregnant women in clinical trials, which obviously has cultural significance, and the waiving of parental consent for older adolescents. So and it's always critical to have a perspective from our communities on each of these topics. So let's go to the next slide, please. I think what's important is to remember that different groups of people and different populations are different. And the reason we have community advisory boards in each community is because each community has different values and beliefs, and we need to be able to respect all of those. Chest feeding is a gender inclusive term, and it acknowledges that not all people feeding a baby human milk from their chests identify as a cisgender woman. But in our environment, that can be seen as alienating in an African context and can actually be seen by a lot of women as being extremely disrespectful. We had a recent consent form come through for a prevention study only being completed in cisgender women, which said chest feeding and not breastfeeding, and that caused quite a lot of confusion in our community. And in the context of this study where breastfeeding is actually, according to the WHO, a biological term, and we're actually wanting to look at transfer of drug concentrations from breast milk into a baby, it was probably appropriate to use breastfeeding rather than chest feeding. And so what is important and respectful in one community might not have the same values in another community. So I think it's important to build these informed consent documents using terminology that is accepted within the community for which those consent documents are actually intended. One of the options would be to use both terminologies, for example, to use the term breastfeeding, which is also known as chest feeding, but you focus on and focus on the intent. There's no intent to harm, there's no intent to exclude certain populations, but just to remember that for some people, these new terminologies as they come along can actually be seen as disrespectful and harmful, and that could actually impact on the rollout of the study. My second example, next slide, please, Natalia. It relates to including pregnant women in clinical trials. We know that pregnant women are included in 1.1% of clinical trials, and 98% of products are not tested in pregnancy or lactation. Pregnant women have been called a vulnerable population. I should put that in inverted commas for many years, which as a more feminist inclined person is perhaps not true. I mean, the fact that you're carrying a baby doesn't take away, doesn't detract from your brain. You can actually still think and you can still make decisions for yourself and for your infant. In some communities, pregnant women don't make the decisions themselves about the infants. They make the decision with the father or with their families about being included. But pregnant women deserve access to treatment and products and should be protected through research and not from research. So overall in the world, it's estimated that the majority of women do take some form of medication through pregnancy, and quite often that pregnancy that medication has not been thoroughly tested in pregnancy, and we have excluded women from the testing process by labeling them vulnerable. And in fact, all we have done is risk shifted, and instead of the product being tested in a controlled clinical trial environment with full and thorough informed consent from that pregnant woman, we have actually just shifted the problem and risk shifted to a later stage when the drug is available in the market, and it's basically given to pregnant women without testing or really understanding the impact that has, the drug concentrations in the breast milk, the drug concentrations that are passed on to the baby. So speaking to the communities about the importance of including pregnant women in clinical trials is critical. And a lot of our communities now actually ask whether or not pregnant women can be included in a study, and whether or not we can encourage the people who are doing the study to enroll pregnant women in our setting. Next slide, please. So my last topic here is the waiver of parental consent for older adolescents. This has occurred in South Africa, in particular in the context of HIV prevention medication, PrEP. A lot of adolescents, we can basically in South Africa agree to medical procedures or medication for ourselves from the age of 12, and that includes contraception or family planning medication. So a lot of people in our communities prefer the depot preparations of progestogen, so either Neristrate or a petogen injection, a 2 or 3 month injection, and can choose to have that contraception themselves from the age of 12. They can consent to have sex from the age of 16. Can already see the illogicality of that, so it doesn't actually work, but they can't consent to be in a clinical trial until we're 18 years old. And so some young people who want to take medication to prevent themselves from getting HIV because they're sexually active between the ages of 16 and 18, there's this disparity where they can actually consent to have sex, but they can actually consent to get contraception, but they cannot consent to be in a clinical trial that would protect them from the consequences of other consequences of having sex, other than falling pregnant for young females. So for young adolescents between the ages of 16 and 17, our the ethics committee at the University of Cape Town has started to ask us whether or not our community would agree with a parental waiver for those 16 and 17-year-olds so that they can sign consent as full adults they don't have to disclose to their parents that they're on the study, that they're having sex, that they're taking medication for HIV prevention, and that they can actually join as full adults in that process. That is something that we go to each of our communities to ask. In the Western Cape, in the studies that I do research in, it is becoming more and more normalized that 16 and 17-year-olds actually do consent themselves, with a waiver of parental consent granted by the community and by the ethics committee. In KwaZulu-Natal, where I'm more newly working, that is not yet as regularly done, but it is something that when we meet with our community working groups, we actually can discuss, because for a lot of in high incidence HIV areas, it might make sense for older adolescents, younger adults, to be able to actually make these decisions for themselves. Next slide, please. So those are the ends of my 3 topics. And just to say that I'm always happy to engage in discussion, and I'd like to acknowledge the community working groups and CAB members who helped me shape these topics of conversation, and also our Research Integrity Office, who came and did a really good talk on ethics for us a few months ago at one of our meetings. So thank you for that.
Well, thank you so much. Thank you to all our speakers for sharing such valuable and practical insights today. We have heard a lot of important perspective here around building trust with communities, navigating cultural considerations, navigating creating meaningful engagement throughout the research journey. And before we move into the Q&A session, we would love to hear directly from all of you attending today. And we have prepared a few short survey questions to better understand your own experiences, the challenges and priorities when it comes to community engagement. So it should be seen on the screen, and we will give everyone a few moments just to respond. So the first one is really the objective on joining us today. The second is really the takeaways from today's session. And also the interest of willing to participate on next discussions. And the last one is the challenges. I'll give everyone a few moments to respond. Can see the responses are coming in. I'll give everyone extra time to respond. Mhm. Answers are still coming in. That's good to see. Great. Well, thank you so much for everyone for participating on the survey. And we can see that there's some interesting results coming in. And on the, yeah, what are your key takeaways? So, yeah, would you be interested in that? Yeah, okay, great. So for question 4, what I found very interesting is what are the top challenges for you as a research site for the sites that you work with or as a sponsor? Can see that not having sufficient staff time or resources to manage the patient pipeline is at least 50% of the answers. 50% are experiencing the same challenge, actually. Yeah. Well, thank you so much, everyone, for responding on this survey. Well, at this point, what we would love to do is to open the floor for questions and hear directly from all of you. Please continue dropping your questions into the chat, and we will go through as many as we can with our speakers. And we would love to make this discussion as interactive as possible, for sure. We will give everyone a moment to submit questions if you haven't done so. But let me check here if we had some meanwhile. Okay. So I've got here one question. I'm not sure who will be taking it. Is how does your team decide which community insights meaningfully shape protocol design, consent language, and participant-facing material? Where do the biggest gaps still exist?
Do you want to start? Thank you. Shall I start? Well, let me start while Thanky's unmuting. So I think sometimes we are restricted. If you're doing a study that's come from a network or come from pharma, you are restricted in terms of study design. It's kind of like you run the study or you don't run the study. So I don't have many examples of communities shaping study design, but we do involve our community a lot in qualitative work and interviews, focus group discussions, in-depth interviews for as things go forward. As far as consent language goes, we have people. We have people read the informed consent. We send things back. If we are writing it ourselves, we often get staff who are involved with the community to write the informed consent as well. So it is done in colloquial language that is actually meaningful to people. We often have to send back translations of consents because they come in, certainly the Xhosa comes back about 2 pages longer than the English and is in a very sort of high level of Xhosa that's not actually really understood, sort of an academic Xhosa rather than a colloquial spoken Xhosa. So we do spend quite a lot of time going backwards and forwards to make sure our consent forms are readable. Patient-facing materials, again, we would work with our community advisory boards to design those if we were given the choice. Quite often we are given things that we don't have a choice about, and then it's just a question of education and explanation and making the best of what you have. Thank you.
I think you have also covered some of the important points that I was going to elaborate on. Regarding the language and the gaps, I will respond by saying that since our research is long-standing, we have not had a challenge whereby there are some barriers or gaps in terms of language, because we normally get the protocols and we get an opportunity to be trained on, as well as to see if it if it aligns with the local language, and we do the translation. We've got a translation team which always look after the language control, whereby the translations are done back translation by different people. So I can say that we always ensure that our protocol, even if they come from the sponsors, but they are in line with what we currently use in our clinical trials. I'm not sure if I'm responding to the right question.
Thanks, Pam.
Thank you. Thank you, Nikki. Thank you, Professor. All right. So there is another question here. How have you best overcome research hesitancy as a consequence of skepticism about healthcare research? Skepticism about healthcare research.
I think, again, that's sort of what we've spoken to all the way through. It's a question of developing and maintaining trust in the community, and being there to provide good and trustworthy sources of information, so that people have a place to go to where they can get their questions answered from people with whom they've got a long-term relationship and have had quite a lot of and have respect. Beth, maybe?
Yeah, from my side, it was quite interesting in COVID with the COVID vaccines because we were doing research, but then they became available in the local clinic. And people were hesitant to go to the local clinic, but we never struggled to recruit people because they just wanted to talk and understand and, and have that interaction. And so it was interesting. It was to me that it was more important to have somebody to talk to. And they were more hesitant, what the government was saying was, but they would come, and we never struggled to enroll people into our studies. So it is a reality, and hesitancy, but it's not necessarily research hesitancy if you've got a good relationship. It's just sort of hesitancy about healthcare, and that we can really help bridge that. But there are those who not interested, who halfway through the study choose to drop off. They've changed their mind, and that's fine. As long as it's done with respect and they're informed. Yeah.
Yeah, thank you.
And maybe to add on that one, with the relationship that we have with our community leaders and other stakeholders, as well as other civil society NGO, civil society representatives, we always get platforms where we present our findings in a language which is more suitable to the audiences. And even though we had some challenges with some of the health personnel, we were able to work with them to allow them opportunities to listen to the importance of our vaccines, so that they can be able to share that information with the audience. And our community engagement team is always out in the field. They target the platforms and the populations where they share the importance of research. And they also address other concerns from the communities, whereby community members will say, if we participate in your clinical research, what are we gaining? So that will mean it is research versus development. They are also able to distinguish, to explain to the communities that the importance of our research is to help the populations from the burden of disease, as opposed to the Department of DSD, which is responsible, or the government responsible for ensuring that the development structures are well in line. Thank you.
Thank you so much, Nagi. Thank you, Beth. Thank you, Professor Ryan. We have another one. about guide framework and guide community engagement. Are there popular frameworks that guide community engagement, or do you have to design one when you enter the community? Is there such frameworks? I would like to know them.
We've got different frameworks whereby we always use the people-centered approach. And I've also mentioned another one, which is the 3Ps framework, whereby we look at the empowerment of our community stakeholders. By going out to the communities, when we educate them, we are empowering them so that they can understand, they can gain information about our clinical trials and the benefits to the broader population. And the partnership as well forms the 3Ps partnership. We cannot do without our stakeholders. By doing that, automatically they have a buy-in of our work that we are doing in the communities. And the third P is prevention. Our research is aiming at preventing the current diseases which is happening in the community. So we've got a couple of frameworks. I'm not sure if my colleagues can be able to add other one, but people-centered approach. And we also have a community engagement policy in place, which guide us how we can ensure that our clinical trials is in line with the GPP.
Okay, thank you, Nagi. I have another question as well. I think the audience is very engaging today. Could you share your experience with ethics approval for inclusion of a pregnant woman? Any extra legal protection required, please? Thank you.
So no extra protection legally is required. What you need is thorough informed consent. You need to be able to explain to that pregnant woman exactly what the risks are. You have to remember that when a drug gets to the point probably of it'd be phase 3 before you're wanting to include pregnant women in efficacy studies. You wouldn't necessarily include someone pregnant in a phase 1 or in a phase 2 study. So by the time a medication gets into a phase 3 study, you usually know quite a lot about it. It's gone through in vitro tests, it's gone through animal tests, and it will have probably 500-600 people's worth of safety data attached to it before you would bring it up in a study. And then some of that data would include the teratogenicity in various animal species, which sometimes, which can translate quite well into people. So you would have to be able to explain all of that information to a pregnant woman, and also make sure she understands how to judge the risks and the benefits. The extreme example of this is like if you had a new medication that might work for Ebola, and you've got a woman who is living with, in the current outbreak in Uganda, and she's pregnant. So this medication might manage her, but if she doesn't have it, she's probably going to die, and she's pregnant. Like, would you just exclude her from the research because she's pregnant when this might actually be life-saving for her in the situation? So it's that's an extreme case, and not all of our cases are kind of at life or death of one or the other, but you do just need to be able to explain those risks and benefits, and be sure that you're actually watching, monitoring properly through the process. But there's no extra legal framework to it. Support from your community, to have a letter from your community advisory board to speak to the ethics committee to say this is an issue. We do need to address this in our community. Pregnant women do encounter this illness, this whatever this problem might be, and they do need to be treated. And at the moment, they're being treated, with substandard treatment because they're not able to be involved in these studies. So that is helpful in that setting.
Thank you.
Maybe just to add one thing that came up with a current study when we wanted to enroll, it was actually adolescents, but these difficult populations, was that the trial insurance goes up when you move into these populations. So it is something for the sponsor to consider. that it might cost, the insurance costs more, but yeah, from a legal point of view, as long as they sign it, they sign a new consent form if they fall pregnant in the study, because it's a separate consent. And again, they can withdraw at any time, but that's the only legal requirement once there's approval.
Thank you. This question came through twice, so really I would like to take the time for this one. What is your take on the issue of decolonizing research methodology and research agenda?
So if that means driving your research agenda from the problems that you experience in your community, that is for me really important. That we we're in South Africa, that we in South Africa answer questions that are relevant to us as South Africans. We focus obviously on our public sector population and the MRC as a whole. The areas of focus are particularly on the burden of disease in our South African population. So I think this is really important. The question, of course, is funding and where the funding comes from to do that, because a lot of African governments, even though we know that we have slightly different research agenda from well-resourced countries, we might not be in the position to fund the research that's required, and that's always where the tension comes in. But I really believe that we do need to kind of as researchers, persuade our governments that research is critical and that we need answers to whether this drug works in our own communities. I'm a clinical pharmacologist. I know that genetics differ from one population to another. And we've seen, with drugs as recent as efavirenz, that we don't need to increase doses in an African population. But we learned that after the fact because there weren't enough Africans in the original research. And that should not happen. If we're going to be using a drug in our communities, we need to be driving that research agenda, but we do need to back that up with the money to run the research, which is more complicated.
Thank you. Thank you so much. I think we are up to time now. We have gathered more questions to be answered. Rest assured to the audience that we will collect them together and we will submit them to and share them with our speakers to respond as well. So we will do that offline as we are up to time now. So we hope today's discussion provided you with practical insights and real-world perspective that you can take back to your own organizations and communities. If you would like to continue the conversation offline with our speakers, feel free to connect with any of us after the session. I will share, someone from the audience asked if we're going to share the materials and the slide deck. We will do that. So you will have the contact details of all the panelists today. A big thank you again to Professor Aurel Nengi and Dr. Elizabeth Spooner for sharing their time and valuable insights with us today. And thank you to everyone who joined us from across the globe. We really appreciate your time and we look forward to welcoming you to our next post-check session. Have a wonderful day. Thank you, everyone.